So to begin our afternoon session on advanced endoscopy, I'm going to introduce a friend and colleague, Rajeev Attam, who is a professor of clinical science at the I don't know how to say, the nascent Kaiser Permanente School of Medicine in Pasadena now, but also, thank goodness, works with us and is the chief of advanced endoscopy at my center in Downey. Rajeev, come on up.
Thank you, Gareth. I hope everybody had a great lunch. Welcome back. And thank you, SCSG, and the organizers for allowing me this opportunity to talk about the abstracts at DDW. No disclosures. I would like to start my talk with congratulations to Dr. Kenneth Chang. Is he here? He was honored with the Master Endoscopist Award this year. Truly well deserved. As you know, he's been a guiding light to a lot of endoscopists, both in the US and abroad, with his immense contributions to the field of gastroenterology. So for the purpose of this talk, I've concentrated on abstracts in EUS-guided interventions, third space endoscopy, tissue resection, endohepatology, and EUS-guided tissue acquisition. Dr. Fan will be talking about ERCP, bariatrics, and artificial intelligence following my talk. Our first study title is the EUS GJ versus surgical GJ. As you know, EUS-guided gastrojejunostomy is becoming increasingly popular for palliation of gastric cartilage obstruction, especially in malignant cases. This is one study which I picked because it shows that EUS GJ can be done in patients who are nutritionally deficient, and it allows for faster resumption of chemotherapy. This was presented by Dr. Bowman at, it's a multi-center US study with the aim to compare EUS GE and surgical GE as primary treatment option for malignant gastric outlet obstruction. All patients with confirmed malignant gastric outlet obstruction were enrolled in the study. Again, these were not randomized to one or the other arm. Primary outcomes were defined as resumption of chemotherapy and feasibility of EUS GE in the setting of poor nutritional status, which is defined as low albumin. And secondary outcomes were defined as adverse event rates, post-procedure length of stay, rate of intervention, and time to resume oral intake. Clinical success was ability to tolerate at least full liquid diet after the stent or the surgical GJ. Results, both arms were comparable in terms of technical and clinical success, but EUS GJ was superior to surgical GJ in terms of resumption of chemotherapy. It took 20 less days to restart chemo in these patients as compared to surgical GJ. EUS GJ could be done in patients with lower serum albumin as compared to surgical GJ, which is commonly, I would say, a cause in our patient population with pancreatic CA when they have low serum albumin from nutritional deficiency. So surgical GJ sometimes is not possible. And rate of adverse events was much lower in EUS GJ as compared to surgical GJ. So in conclusion, EUS gastroenterostomy can be performed among nutritionally deficient patients and allows for early resumption of chemotherapy, which is a big deal in these patients because you do not want a longer interruption of chemotherapy while they're going treatment. The second study comparing EUS GJ was to EUS GJ versus surgical GJ and enteral stenting, which is again on a popular modality of treating malignant obstruction. This was a study from two hospitals, Mayo Clinic and a university hospital in Brussels. Again, they enrolled all consecutive patients who underwent EUS GE and enteral stent or surgical gastroenterostomy at these two academic institutions. Primary outcome was defined as need for re-intervention. Secondary outcomes are technical and clinical success, length of hospital stay, and rate of adverse events. Clinical success in this study was defined as ability to tolerate at least a full liquid diet within 5 days. Results, all three arms at clinic had similar technical success rate, but EUS GJ had higher clinical success as compared to surgical GJ. And I think the reason for this was they defined clinical success as ability to take oral intake at 5 days. And from previous studies, we know it takes about a median of 6 days after surgical GJ for patients to tolerate oral intake. So this may have contributed to lower clinical success in this study. But again, EUS GJ was superior in terms of re-intervention rates. length of stay days, and had much lower rate of adverse events. So in conclusion, this large cohort study demonstrates a long-term durability and safety of EUS GJ as an alternative strategy for gastric outlet obstruction palliation. And I think based on these studies and the previous published data, EUS GJ is now becoming the primary or the first modality for management of gastric outlet obstruction in patients with malignancy at least. Moving on to another application of EUS intervention, and this is for gallbladder drainage. This study from Wake Forest University Hospital titled EUS guided gallbladder drainage versus percutaneous gallbladder drainage in acute cholecystitis, a propensity match analysis, aimed to compare clinical outcomes of EUS GBD versus PT GBD in patients with acute cholecystitis. Again, it's a retrospective evaluation of all patients with acute cholecystitis undergoing undergoing EUS GBD with cautery enhanced lumen opposing metal stents or the hot axios. Technical success was defined as appropriate placement of lamps or cholecystostomy tube in the gallbladder lumen. Clinical success was described as resolution of abdominal pain and fever with normalization of WBC count by 96 hours without recurrence of acute cholecystitis. Results, as expected, both study arms had very high success rates, 90 to 100%. Clinical success was also similar in both the arms, but EUS GBD was superior to percutaneous gallbladder drainage in terms of reintervention rates and adverse events rates. So in conclusion, EUS GBD and PT GBD had similar rates of technical and clinical success. However, EUS GBD had lower reintervention and fewer adverse event rates. And this may again have to relate with the size of the drainage catheter that you're deploying across the gallbladder in EUS GBD versus percutaneous, which is a smaller tube. Moving to EUS guided biliary drainage, we know we've been using EUS guided hot axios deployment for drainage of bile duct. So how do these do over long term? This is a study from Jeremy Albois from France, short and long-term efficiency of EUS guided biliary drainage using electrocautery enhanced lumen opposing metal stents in case of failed ERCP, a large prospective study of 118 cases. This is a prospective observational single center study, including all EUS BD for distal malignant obstruction with 6 millimeter cautery enhanced lumen opposing metal stent. These are all done in a 4-year period from 2017 to 2021. The primary objective was evaluate the long-term rate of stent dysfunction. Secondary objectives being evaluate the short and long-term technical and clinical outcomes, and to identify the risk factors for this stent dysfunction. I think 70% of the patients in this study had pancreatic CA. Results, as expected, technical success and clinical success were again very high, 97 and 96%. Stent dysfunction in the study period occurred in 16.1% cases. And they went ahead and further analyzed the data and identified 3 risk factors for stent dysfunction in these patients. And these were cholangiocarcinoma, which again could lead to tumor ingrowth into the stent, presence of duodenal stent in the and pre-procedure bile duct diameter of less than 14 millimeters. So in conclusion, EUS guided bile duct drainage with electrocautery enhanced lumen opposing metal stents has high technical and clinical success rates. Rate of stent dysfunction was 16%, and the risk factors are as above. Moving from EUS guided interventions to third space endoscopy. This year we had multiple abstracts on techniques to reduce post-POEM reflux symptoms, because that POEM itself has established its place in treatment of achalasia and spastic esophageal disorder. Now we're in the next step. We're trying to make it safer and better. This is one interesting study from Northwestern Feinberg School of Medicine, impact of short gastric myotomy on gastroesophageal reflux disease following parole endoscopic myotomy. In this study, they aim to study post-POEM GERD in patients who had short, which is 1 centimeter gastric myotomy versus 3 centimeter gastric myotomy from a control group. So data from 30 patients with 1 centimeter gastric myotomy was compared to 30 matched historical controls. Symptomatic GERD was assessed by GERD-Q scores and post-POEM endoscopy. reflux findings were assessed at 4 to 15 months post-POEM using upper endoscopy. So in this group of study patients, the mean GERD-Q scores for short gastric cardiac myotomy was actually lower than the historical controls. And this was significant. Also, interestingly, short gastric myotomy had low POEM ECOG scores as compared to controls, suggesting higher clinical success. They had lower rates of reflux esophagitis, lower severity of reflux esophagitis, and lower mean reflux symptoms. Interestingly, even though the reflux esophagitis and GERD symptoms are lower between the two groups in the short gastrostomy gastric myotomy group, there was no difference in PPI usage between the two groups. So both groups actually had the same amount of PPI usage. So in conclusion, short gastric myotomy POEM was superior to standard gastric myotomy for post-POEM GERD symptoms, rates of esophagitis, and severity of reflux symptoms. POEM-F has been reported as one option for treatment of GERD symptoms after POEM. And there is some suggestion that this helps in long-term care of these patients. But the question remains, how many patients actually need POEM-F? In POEM-F, you're combining POEM with TIF at one session. So the question is, how many patients actually need POEM-F? So this is a nice, interesting poster that I found from UC Irvine. So they analyzed they analyzed 132 patients who had POEM. These are for achalasia and spastic esophageal conditions. Of the 132 patients, only 9%, that is 12 patients, actually needed TIF. And these are the patients who had post-POEM refractory GERD symptoms, not getting better with PPIs. So only 9% actually needed TIF. So in 91% patients, you can actually manage them with lifestyle modifications or antacids. And the patients who had TIF had no worsening of dysphagia. So this kind of flies in the face of POEM-F. You really don't need POEM-F in all patients. GPOEM, another option for patients with gastroparesis. We have studies from US with outcome data. So this is one multi-center study from France presented by Jeremy Jacques, GPOEM and refractory gastroparesis for whom long-term outcomes and predictive score to improve patient selection. So they enrolled 46 patients who had GPOEM, so refractory gastroparesis, and had 3-year follow-up in these centers. They had a pretty decent clinical success rate of 65.2%, which is in line with the US data, which is about 65 to 77%. The median GCSI score decreased from 3.3 to 1.8, showing high clinical efficacy in these patients. And there was no difference in outcomes based on the etiology of gastroparesis. They were able to identify patients who would do well with GPOEM, and these are the patients who had nausea subscale score of less than 2, had satiety subscale score of more than 4, bloating subscale score of more than 3.5, and H4 retention percent more than 50%. So these patients tended to do better with GPOEM than the others. So in conclusion, the authors say clinical success of GPOEM for refractory gastroparesis was 65% at 3 years. A predictive score offers an easy tool that should be confirmed in other studies. Moving to ZPOEM, which is again now has established its role in care of Zenker's diverticulum. This is a long-term data study from multiple centers across the country. Long-term outcomes of Zenker's parole endoscopic myotomy, or ZPOEM, for treatment of Zenker's diverticulum. Aim of the study was to study long-term outcomes of 2 or more years following ZPOEM, and they enrolled all patients who underwent ZPOEM for Zenker's diverticulum or had at least 2 years follow-up. Clinical primary outcomes are defined as clinical success, which was again defined as improvement in dysphagia score to less than or equal to 1 without need for further interventions. And secondary outcomes are rate of recurrence and rate of reintervention and adverse events. So I had 81 patients in the study with a mean diverticulum size of 2 centimeters to 4.6, very high technical and clinical success of 97, 98%. Adverse events in first 30 days was 7.4%, which included leak aspiration pneumonia, and pneumomediastinum. Mean procedure time was anywhere from 26 to 1 hour. Leak was seen in 4 patients, and 2 required endoscopic reintervention with clip placement, and 2 were managed conservatively. And recurrence occurred only in 1 patient out of 81 at 7 months. So in conclusion, ZPOM is highly safe and effective treatment for Zenker's diverticulum with durable treatment effect for at least 2 years. Moving now to tissue resection, this is an interesting study from Yutaka Saito from Japan, where they described long-term outcomes after ESD for colorectal epithelial neoplasms, a Japanese perspective multicenter cohort trial. Aim was to determine the long-term outcomes of ESD in this large multicenter study. They included 1,883 patients with 1,965 lesions who underwent ESD during the study period. Lesions more than 2 centimeters in size were analyzed. Primary outcomes are defined as 5-year survival and intestinal preservation rate, meaning how many of these did not require surgery. Disease-specific survival and overall survival were also compared between complete resection and non-complete resected lesions. Results: about 90% of patients had complete resection with ESD for colorectal polyps. Surgery was required in non-complete resection at a rate of 64%. And in 5-year outcome data, patients who had complete resection of lesions had a very, had 100% 5-year survival and a very high intestinal preservation rate of 98%. So they did not need surgical intervention in 5 years. As compared to the patients who did not have complete resection, only 15% patients had intestinal preservation at 5 years. So about 85% actually required some sort of a surgical maneuver to remove that lesion. So this study shows favorable long-term outcomes after ESD of 2 centimeter larger colorectal polyps with 5-year disease-specific survival of 99.6%. Now, ESD is popular in Japan and parts of Asia for removal of colorectal polyps, but in the Western world, piecemeal EMR with snare tip ablation of margins is still the preferred way of removing large polyps. So this is one prospectively a prospective study of randomized patients between ESD and piecemeal EMR that was presented at DW by Jeremy Jacques' group. Again, it came from France. So the aim of the study was to determine optimal treatment strategy, ESD versus piecemeal EMR for management of laterally spreading lesions in the colon. ESD was compared to piecemeal EMR along with snare tip thermal ablation, which is what endoscopists are using these days for management of these polyps. Primary outcome was defined as recurrence rate at 6 months. Secondary outcomes were rates of R0 resection, complications within 30 days, technical failure, and surgical referral rate over 6 months. Results. So they had about 359 patients who were randomized to ESD or piecemeal EMR, and 60% of the lesions were in the right colon. ESD was successful in 98% of these patients. At 6 months, recurrence with ESD was very low, 0.6% as compared to piecemeal EMR, which is 5.1%. This was significant. R0 resection was pretty high in ESD at 94% as compared to piecemeal 12.1%. As expected, mean procedure time was longer with ESD, and perforations were higher in ESD, but were not statistically significant as compared to piecemeal EMR. So in conclusion, ESD is superior to piecemeal EMR regarding 6 months recurrence rate. R0 resection exceeds 90%, avoiding costly and unwanted repeat colonoscopies. And piecemeal EMR seems to be associated with a high risk of histological loss of histological information, which could be detrimental to patient care, and especially when they have advanced malignancy. Moving to endohepatology, yesterday we were treated to a wonderful case presentation and also a great lecture by Dr. Samarcino on endohepatology, US guided PPG. This is an abstract submitted by Mark Morishisi. It's a multicenter US study. US guided portosystemic pressure gradient evaluation predicts liver histology and clinical parameters of liver disease. The aim of the study was to evaluate correlation between EUS PPG and clinical markers of portal hypertension, non-invasive markers of liver disease, and liver histology. So they measured EUS PPG gradients and compared gradients more than 5 and 10 millimeters mercury against markers of liver disease, including APRI score, FIB4 and MELD scores, transient elastography, and liver histology. Results: EUS PPG correlated very well with markers of clinical disease, liver disease, including FIB4, APRI, and MELD scores. EUS PPG of more than 5 was able to patients who had EUS PPG more than 5 were 6 times more likely to have advanced fibrosis and histology, that is stage 3 or 4. It was able to diagnose patients with liver disease even when the clinical markers of the disease were not present. And EUS PPG did not correlate well with transient elastography. So in conclusion, EUS PPG demonstrates strong correlation with clinical parameters of portal hypertension and histological evidence of advanced fibrosis. EUS PPG may be more sensitive indicator of advanced liver disease than the current non-invasive testing available. Moving to the last abstract, this is a randomized study of wet suction versus low pull FNB by Neil Sharma. It's a multi-center study, blocks benign liver optimal core study, safety and efficacy of EUS-guided benign liver FNB core biopsy using wet suction versus slow pull technique, a randomized multi-center study. The wet suction technique included a 19-gauge FNB needle preloaded with 3 cc of saline with suction valve in the off position, and the slow pull technique included the 19-gauge FNB needle with 2 centimeters slow pull back of stylet while the needle was passed in the lesions. Liver biopsy time was the time taken from inspection of liver to tissue acquisition. So patients were randomized to one versus the other technique. Results: they had total 153 patients, 73 and 78 in the 2 arms. There was no difference in liver biopsy time between the 2 studies, 2 techniques, but wet suction technique was superior to slow pull FNB in terms of total length of fragments retrieved, length of longest fragment achieved, total number of portal tracts that were obtained, and total number of fragments that were obtained. So in conclusion, this modified wet suction technique resulted in greater histological specimens, and which included total fragment length, total number of fragments, and number of portal tracts. And this may aid the pathologists in their interpretation of the disease. That is, thank you.